There's a new review paper out about the European guidelines for cardiovascular disease that describes them as misleading. You're going to find out all the details about it here today on Jimmy Rants. JimmyRants.com is the website, and as always, you can engage live in the content. Come follow me right here over on Instagram. I am Jimmy Rants over on Instagram. Makes it easy to find, right? We do go live Monday through Friday, 11 a.m. Eastern Time. Thank you so much for being here today, you guys. We're also simulcasting over here on my Facebook page as well as over on the Twitch app. And I'll remind you, Twitch, I've had more people watch on Twitch lately than all the other formats. And so go download the Twitch app, follow Jimmy More Rants, and you can watch the show from Twitch. If you missed the live, you can watch it on the replay right here on the Jimmy Rants Instagram feed. It'll be on IGTV. Just as soon as this is over, we throw it right up there for you. You can also watch the replay over on Twitch. It's also going to be on YouTube. If you type in a keyword Jimmy Rants, you'll find the show over on YouTube. And then finally over at JimmyRants.com. So speaking of YouTube, by the way, today is Tuesday. And on Tuesdays, I do a Jimmy Rants on Living La Vida Low Carb show. So all of my videos are obviously up on all those formats I just mentioned. But on the Living La Vida Low Carb show today, I will have one of the best of Jimmy Rants. So go check that out, LLVLC.com, or wherever you listen to podcasts, you can access the best of Jimmy Rants on Living La Vida Low Carb. All right. So guys, you know what I like to do a lot is look at papers, and I'm all the time looking at research papers. In fact, just before I came on the air, I had a practitioner send me a paper that she had written about on her Instagram page, and I said, hey, can you send me that paper? I would love to articulate it on Jimmy Rants. So she just sent it. So I'm all the time trying to stay on the cutting edge of what's being said out there in the research. And I do that because I think it's important for you to know not just the good studies that show positive things about keto and fasting and cholesterol and all the things, but also the bad. And then that way we come here and break it down. And I think I do a pretty good job of breaking down studies for you guys. Today I have a review paper. So here's a review paper, again, that I got from a doctor friend that I have known for many years. Dr. Uffe Ravnskov is his name. He's a researcher out of Sweden. He's very well known as a cholesterol skeptic. And he created many years ago this organization called THINCS, T-H-I-N-C-S. And basically it's an acronym that stands for, we're a bunch of people that don't believe cholesterol is the enemy in your health. I forget what all the letters mean, but go look it up, T-H-I-N-C-S. And you can see everything that he's doing. You can see the people who are a part of that. A lot of the members of THINCS are anonymous because you get ostracized if you go against what is said about cardiovascular disease, what is said about cholesterol and its role in your health. And the unfortunate thing is this cholesterol hypothesis is still so deeply ingrained in our culture, and especially the medical and research culture, that it's hard to break. It's something that Dr. Ravnskov has dedicated his entire career to. In fact, in my book, Cholesterol Clarity, Dr. Ravnskov is one of my experts. So on the back, you can see Dr. Uffe Ravnskov. There he is right there. So this is the guy that wrote this paper I'm about to read to you. And he was one of the Moment of Clarity experts in cholesterol clarity. But cholesterol, man, like this book came out in 2013. I wrote it in 2012. Came out in 2013. And even then, it was already old news that cholesterol was not this grand enemy in your health. And yet they continue to repeat that lie time and time and time again, to the point that people freak out about their cholesterol and they really don't understand that there is no such thing as the disease of high cholesterol. I hate to break it to you if you believe that. I hate to break it to you if you're on some kind of a cholesterol lowering medication to try to lower your cholesterol because you think it's an enemy in your health. It simply is not. And I highly recommend, if you want to learn the basics, It's a little self-aggrandizing, but it is a pretty good book. Read Cholesterol Clarity so that you can learn the basics of why cholesterol is not the enemy in your health. You'll read in chapter 5 exactly everything about statin medications and why they're bad news for your health and why they're not really a preventative when it comes to heart disease. They actually increase your risk of heart disease. Statin drugs do. You can read in chapter 10 where the doctors, why they're so clueless about cholesterol. And you go to talk to your doctor and they try to make you feel bad because you're not worried about your cholesterol. I talk all about that, why they don't understand. Well, this paper I have today, and if you're joining us late, I have a review paper that was published in a journal, and it calls the new cardiovascular disease guidelines out of Europe misleading. Now, you might be an American and think, well, what do I care about the European cardiovascular disease guidelines? That doesn't apply to me. Oh, you want to bet? Because once things get implemented in one part of the world, it's generally adopted by most of the world. And America has been the worst of the worst on this. And the American Heart Association is definitely in cahoots with what the European guidelines for the prevention of cardiovascular disease have said. So this review, this article is written in a journal, Expert Review of Clinical Pharmacology. And like I said, the lead writer and researcher on this paper is Dr. Uffe Ravnskov. Let's see, there's a few other names you might recognize. David Diamond, Dr. David Diamond, another cholesterol skeptic. Zoe Harcum, who's also out of the UK. Malcolm Kendrick out of the UK. And Ralph Sundberg is out of Sweden, as is Dr. Uffe Ravnskov. All right, so that's where all of these people are from. In the introduction, they say the European Society of Cardiology and European Atherosclerosis Society recently published 3 major revisions to their guidelines for managing chronic heart disease, blood lipids, and diabetes. So we are scrutinizing in this paper these guidelines in detail, and the authors of this paper are the authors of the new report. Those 3 changes that they made to the European guidelines have ignored many studies that conflict with their conclusions and recommendations. Now, how many times have we seen that? Like, we just saw that with the 2020 dietary guidelines here in America. They put out these guidelines and they did not look at one single study looking at low-carb ketogenic diets. Not one single study was considered. Why? Because all those studies looked at weight loss, they looked at heart disease, they looked at insulin resistance, metabolic syndrome, they looked at diabetes, cancer, down the line. And the excuse that was given as to why they didn't pay attention to those studies was, well, the dietary guidelines for Americans is for people who are generally healthy how to eat. Well, most of the population is not generally healthy. Most of the population has one of these conditions that, had they looked at the totality of the science, low-carb diets, ketogenic diets certainly would have shined and shined strongly. So that's kind of where we are. All right, so the authors of the guidelines ignored the LDL cholesterol, this LDL-C, of patients with acute myocardial infarction is lower than normal. So these are the people that have had heart issues. That high cholesterol is not a risk factor for people with type 2 diabetes. That the degree of coronary artery calcification, so that's where the CT heart scan, they look for calcified plaque, is not in any way associated with your LDL-C, and that 27 follow-up studies have shown that people with a high total cholesterol or a high LDL-C live just as long or longer than those people who have lower cholesterol. They've also ignored the lack of any exposure response in the statin trials, that several of these trials have been unable to lower cardiovascular disease or the number of people who die from cardiovascular disease, that no statin trial has succeeded with lowering mortality in women, elderly people, or people with type 2 diabetes, and that cholesterol lowering with statins has been associated with many serious side effects. So they're going to get into the nitty-gritty of all those things in this paper, and I'm glad you tuned in today on Jimmy Rants. This one is on fire. And if you just joined us, we're about to read from this review paper. They took a look at the European guidelines for the prevention of cardiovascular disease, and the authors of this paper, who are a lot of cholesterol skeptics, are like, look, this is misleading. It's going to lead people down a very dangerous path if they follow those guidelines. So let's get into it. Introduction. For more than a half a century, health authorities all over the world have considered high blood levels of cholesterol to be the primary cause of cardiovascular disease. Although an almost endless number of observational and experimental studies have documented that this idea does not satisfy any of the criteria for causality. In other words, they're saying causation leads to manifestation of the disease. No, like it hasn't really been shown. Recently, though, new European guidelines for the diagnosis and management of chronic coronary syndromes, that's heart stuff, dyslipidemia, stuff with your cholesterol, and diabetes were all published, and there were a total of 218 pages in these guidelines. Each of the papers included more than 500 references, but not a single one to the numerous contradictory studies that would provide that recommendation false. We therefore decided to analyze these guidelines in greater detail to present the findings which we believe were ignored. Don't you hate that? People say, well, trust the science. This is what the science says. The science says science. Like they think science is one singular thing. And more times than not, science is not just one side. Science is not just one view. Good science shows angles from every view. Good science says, okay, you have a paper that shows this, but I have another paper that shows the opposite, and then you start scrutinizing the quality of that science. Like, I'm so over of, you just got to trust the science. There is no the science in most cases. Many cases, it's a totality of evidence on both sides. So let's look at some of these claims they have in these new European guidelines for the prevention of cardiovascular disease. One of them is high total cholesterol and high LDL-C are somehow mattering. And what they're saying in this review paper is they're not really risk factors. High cholesterol levels are not a risk factor for cardiovascular disease. To evaluate the risk of cardiovascular disease, the guidelines by the European Guidelines for the Prevention of Cardiovascular Disease recommend the SCORE, that's an acronym, S-C-O-R-E, cardiovascular risk chart. According to these charts, the 10-year risk of cardiovascular disease is by far the highest after the age of 60. This is, of course, correct, but the cause cannot be because of high total cholesterol or high LDL cholesterol. There was an analysis of 19 studies where the authors followed more than 68,000 elderly people for several years after having analyzed their LDL cholesterol. Almost all of those highest values lived the longest. None of the studies found the opposite. So if you're looking at total cholesterol or you're looking at LDL cholesterol, and especially of an older population, the evidence just doesn't show that it's a negative thing. In fact, it's just the opposite. People with higher cholesterol at those older ages tend to live longer. And I talked about this in Cholesterol Clarity, by the way. One of my experts was Chris Masterjohn, who now is a PhD, Dr. Chris Masterjohn now. But when he was my expert in the book, he noted that in traditional cultures that were free from heart disease, people that were in their 60s, 70s, and 80s, the older population, they tended to have higher cholesterol. And so normal cholesterol is considered 200 milligrams per deciliter. Guess what the normal was for people in this traditional culture, eating real whole foods, lots of healthy fats, minimal carbohydrates. Guess what their normal total cholesterol was in their 60s, 70s, and 80s? Would it shock you to learn it's 300? 300. And so these people that go to see their doctor now, that are in that age range, and they start to see elevations in their cholesterol, the doctor does what? The doctor freaks out. Oh my God, you're going to have a heart attack tomorrow if you don't lower your cholesterol. And so what do? They write a prescription for a statin drug. They tell them they need to cut out their saturated fat and cholesterol in their diet. And then they obediently do it. Now what happens? They lower their cholesterol, yes. They cut out saturated fat and cholesterol, yes. But that's the wrong thing to do. That's the very point in their life when they need more cholesterol in their body. Why? Because older bodies tend to have more inflammation. And what is one of the roles that cholesterol plays in the body? An anti-inflammatory effect. Oh, did you know that? Did you just learn something? Did you know cholesterol in your body, one of its purposes is to put out the fire of inflammation in your body? And so if you're an older person, you tend to have more susceptibility to inflammation. Don't you want more of those firefighters in your body putting out the fire of inflammation? You bet you do. So don't freak out if you're over the age of 60 and you've got a high cholesterol. That's not a disease that now needs a medication that didn't exist 50 years ago. You just need to use that and be healthy by it. The unintended consequence now of lowering cholesterol levels, lowering the amount of saturated fat and cholesterol people eat, artificially lowering cholesterol levels through a statin medication, is older people start to have more susceptibility to brain health issues. Statins have been found, as well as low-fat diets, have been found to be a causal factor in Alzheimer's disease and other kind of metabolic health diseases, which Alzheimer's would be one of them, Parkinson's. You also start to have dementia set in early, susceptibility to a lot of things that just doesn't need to be there. And oh yeah, by the way, when you take away the firefighters, that fire is still in there. What's going to put out the fire? Nothing. So there's an increased risk of heart disease and diabetes and metabolic damage galore. Do you see why the authors of this paper criticizing these new guidelines out of Europe are saying, look, we need to stop trying to vilify total cholesterol and LDL cholesterol. That's the thing these older people need more than anything. That makes sense? Since then, similar findings regarding LDL-C have been presented in a Korean study of 749 dialysis patients, an Italian study that included more than 1,000 community-dwelling people, in a study of more than 2,000 American Indians, and in 2 studies from Israel, including more than 5,000 patients of healthy people, in a Spanish study involving more than 50,000 high-risk community-dwelling people, in a Slovakian study including almost 500 patients with hypertension. 5 of these studies included young and middle-aged people. Furthermore, in a British study including almost 100,000 people above the age of 80, followed for 15 years, those who had the highest total cholesterol were the ones who lived the longest, both among those on statin treatment and those without. And the moral of this story is, it's not about the cholesterol. And this is something, again, I have been trying to hammer for years with this book here. And a lot of you guys say this book changed your life because it really kind of made cholesterol easier to understand for you. But the truth is, high cholesterol is not an enemy. High cholesterol is not a disease state that needs to be dealt with. High cholesterol needs to be celebrated. And I don't know about you, but as I get older, I want high cholesterol much more so than I want lower cholesterol. And lower cholesterol comes with its problems too. You start to have brain health issues, which we talked about, the onset of dementia. You have mood disorders. You have anxiety and depression kind of kick in just because you don't have enough cholesterol in your body. So let's not take out the miracle substance in your body that's helping to manage inflammation, prevent some of these mental health decline. It just serves so many good purposes. And in younger people especially, it helps to manage a lot of the hormonal pathways that are going on in your body. So cholesterol is not the enemy. A relevant question is why many previous studies of young and middle-aged people have shown that high cholesterol is a risk factor for cardiovascular disease. A likely explanation is that mental stress may be a more common phenomenon among young and middle-aged people than among senior citizens. Mental stress is able to raise your cholesterol. Did you know that? When you're under a lot of mental stress, that raises your cholesterol? Did you know that? And part of the way that works is mental stress raises inflammation in your body. And when inflammation goes higher, guess what else goes higher to try to deal with it? Cholesterol. Are you seeing why cholesterol is a good thing in your body? Are you seeing why lowering it is the antithesis of being healthy? It is. And it may cause heart disease by other mechanisms than just by raising your cholesterol. This is the thing. Cholesterol is not the reason why you get heart disease. It's not. Neither is saturated fat. The reason you get heart disease is one thing primarily: inflammation. Inflammation can be brought on by bad food in your diet, vis-a-vis refined carbohydrates and refined vegetable oils, seed oils. That's one thing. You can also get cholesterol to go, have issues with your heart because of stress and not managing that stress properly. There's so many mechanisms that would lead that to happen. And all of those things will raise your cholesterol in the interim, trying to save you. People worry about, like, I don't want to eat too much cholesterol because I'll be unhealthy. Well, guess what? The number one source of cholesterol in your body is not from what you eat. Your body is a cholesterol-making machine. If you don't eat cholesterol in your diet, guess what your body does? It ups the production of cholesterol. If you eat plenty of cholesterol in your diet, guess what it does in your body? It downregulates the production of cholesterol. There is no such thing as, oh, I got to cut back on my cholesterol so my cholesterol will go down. No, your body will just kick in the natural process to make exactly what it needs, because your body is not stupid. Your body knows that if you're under inflammation, you need cholesterol because it's the firefighter in the body. One argument that was used in these new European guidelines is based on the Mendelian randomization, which has shown that lower genetically determined LDL-C concentrations are associated with having a lower all-cause mortality, which is every cause of death. However, as pointed out by Burgess et al. In their paper, Power Linkage Disequilibrium, Pleiopatry, Canalization, and population stratification have all recognized as potential flaws in the Mendelian randomized approach. That's a long study that they put in there. That's the title of it. But according to the guidelines for the management of dyslipidemia, which is crazy high cholesterol levels, degree of coronary artery calcification, which is that CAC score. So when you get a heart scan, they're looking for the CAC score, coronary artery calcification, should be used to classify your risk for cardiovascular disease. It is correct that a CAC is a risk factor. In fact, it is by far the strongest risk factor ever measured, which begs the question, why are those so quick to do statin medication based on a high LDL-C or high total cholesterol without doing that CAC first? Because if you get a high total or high LDL-C and yet your CAC score with your heart scan comes back a big whopping 0, that high cholesterol means nothing. Have you gone to see your doctor and had a high cholesterol and he said, hey, let's do a heart calcium score before we put you on any medication? I would bet no, not likely. In the study by Cavalsi et al., for instance, the hazard ratio in men was 7.8, in women 4.8. However, they had not analyzed the association between the coronary artery calcification score and the LDL cholesterol. Data from the MESA study showed that nearly half of those individuals who would be eligible for statin medication Half of them, you guys, had a CT heart scan of 0. So they were eligible to be on a statin based on their LDL and total cholesterol, but because they had a CAC of 0, they didn't really need it. And in a study of 304 women by Hecht et al., the authors found that the association between LDL-C and coronary calcification was slightly inverse. In fact, statin treatment may increase coronary calcification. Did you catch that? If you take a statin medication, there is a study that makes the claim that it will increase actual calcification. In other words, increase heart disease. Can you see why the authors of this paper are very upset at the European guidelines trying to help people with cardiovascular disease to pay attention to LDL-C and total cholesterol as a primary risk marker? Because that leads them to take statins, and now we see those statins increasing coronary calcification. It is therefore highly unlikely that lowering LDL-C will actually lower this CAC. This is why I think we've gotten in big trouble treating numbers on a paper rather than treating disease. We should have been treating disease all along, and people, when they go to see their doctor, they think by lowering cholesterol, they are treating some disease in their body. High cholesterol is not, has not ever been, and will never be a disease. High cholesterol is not a disease. High cholesterol is a state based on things going on in the body, but high cholesterol in and of itself is not a disease. Got it? The next thing that they want to correct in this paper, high cholesterol, not a risk factor for people with type 2 diabetes. They think once you get diabetes that suddenly, oh, you got to really deal with your cholesterol. Oh my gosh. I'm going to remind you in case you've forgotten about this. Diabetes, heart disease, metabolic syndrome, PCOS, I can go down the line. All of these manifestations of disease that we classify in all these different categories, they are all the same disease of insulin resistance. Don't ever forget that. Every single one of them is insulin resistance, just manifested in different ways. And so when someone has type 2 diabetes, they don't need to deal with their high cholesterol. It is generally viewed that having a high LDL-C is a cardiovascular risk factor for people with type 2 diabetes. And according to these new European guidelines, all high-risk diabetics should immediately go on a statin medication, no questions asked. However, in a follow-up study of 31,000 people with type 1 diabetes between 2003 and 2011, LDL cholesterol was not a risk factor at all in the elderly. In a 7-year follow-up study of 313 type 2 diabetics, neither total nor LDL cholesterol was a risk factor for non-fatal or fatal coronary heart disease. The same result was seen in a 9-year follow-up study of cardiovascular mortality in 113 type 2 diabetics, and in an analysis of cardiovascular disease in 4 follow-up studies of 1,000 patients who had type 2 diabetes. Furthermore, in a recent study using data of almost 500,000 people from the UK Biobank, the authors found that levels of circulating LDL-C were negatively associated with the presence of type 2 diabetes, both among patients who were on medications for lowering cholesterol and among those who were untreated. I'm going to scream it until I'm blue in the face. High cholesterol is not a disease. Next point. High cholesterol, not a risk factor for people with familial hypercholesterolemia. So this is the genetic predisposition for having high cholesterol. According to these new European guidelines, all people over the age of 50 who have a family history of cardiovascular disease in a as a first degree relative should be screened. It is a fact that among young and middle-aged people with cardiovascular disease, more of them have familial hypercholesterolemia than in the general population. This finding apparently supports the cholesterol hypothesis. However, Several studies have shown that on average, people who have FH, familial hypercholesterolemia, live just as long as other people, and that the cause of any kind of premature cardiovascular disease in those with familial hypercholesterolemia is a small subset of these individuals develop cardiovascular disease, have an inherited increased coagulation factor as well. So you can test for that increased coagulation factor and see if you fall in that category. We don't need to make blanket recommendations for a whole classification of people based on faulty data or assumptions being made, which is what they did. All right, let's shift into why cholesterol lowering is not beneficial. Cholesterol lowering does not lower your risk of cardiovascular disease. One of the central messages of the authors of these new European guidelines for cardiovascular disease is that it is an established fact that an increased level of LDL cholesterol, the so-called bad cholesterol, is the cause of atherosclerosis and heart disease, and that it should be lowered as much as possible. I've already explained, LDL is not the enemy in your health. It's just not. Inflammation is. Inflammation is, was, and always will be the reason why you have heart health issues. Not your LDL. It's inflammation. So get the inflammation out of your body. Get rid of refined carbohydrates, refined fats like seed oils. Get rid of stress in your life and toxic people out of your life. Exercise, because that also lowers inflammation. Meditate, all the things. And you do those things and you don't have heart disease. They argue in their new guidelines that this message of LDL cholesterol being the bad guy is evidenced by the presence of exposure response, for example, a correlation between the degree of cholesterol lowering and the outcome. So they think, okay, well, we lowered your cholesterol commensurately this much, and now look at the outcome. Therefore, this caused that equals that. And that's how they came up with LDL mattering. The guideline author's argument for the presence of exposure response is based on a review by a researcher named Ferrant et al. To calculate exposure response, these authors referred to more than 30 different studies looking at statin drugs, but in their calculation of exposure response, they have only used data from 12 of those 30 studies. If data from all the trials were actually used, they found there was no exposure response. In fact, total mortality increased. In other words, the total amount of death increased in 8 of the trials, and cardiovascular mortality in 7 trials also showed an increase in mortality, although not with statistical significance. Another contradiction is that in a study including almost 140,000 patients with acute myocardial infarction, LDL cholesterol at the time of admission to the hospital was lower than normal. We put that study in my book, Cholesterol Clarity, that study was the one where they had people admitted to a hospital with some kind of cardiovascular heart health issue. They had chest pain, they had a heart attack, something. Half of those people who experienced a heart attack or chest pain or some other issue with their heart, half of them had totally normal, supposedly healthy levels of cholesterol. So cholesterol is the reason why people have heart health issues, cardiovascular issues. Why would half of the people coming in with heart health issues into an emergency room, why would they be having normal levels of cholesterol, either through drug manipulation or just naturally? Makes you wonder. The author's conclusion was that LDL cholesterol should be lowered even more. So in that study where they found that half the people admitted to the hospital had normal levels of cholesterol, the author concluded, oh, well, they must not have been low enough. Remember, under 200 considered healthy. Under 200 is considered good. And they were under 200, but it wasn't good enough. You see how the whole argument falls apart? In another study with the exact same result, the authors followed the patients for 3 years afterwards. They found that total mortality amongst those with the lowest levels of LDL cholesterol was twice as high compared to those with the highest levels. In other words, if you have a heart attack and you have high cholesterol, you better keep that high cholesterol because it's more likely than not to help you stay alive. Are you seeing all the lies we've been told about LDL all these years? Many cholesterol-lowering trials have lowered the risk of non-fatal cardiovascular events, as there is no exposure response between LDL-C lowering and mortality. The explanation must be that the benefit is due to things other than cholesterol lowering. Well, one of the things we know about statin medications, which the name brands Lipitor, Crestor, Zocor, all the ors on the end, all of those are the cholesterol lowering ones. So I remember when there was a shift, when I first started talking about cholesterol and looking it up in the late 2000s, it was all about cholesterol lowering. But then there was a shift that started to take place early in the last decade, something like 2010 to 2015. And they started saying, oh, no, it's not the cholesterol lowering effects that statin medications give. It's the inflammation lowering effects. And so they shifted their reason for why people should be on it. However, this benefit is minuscule because no statin trial has succeeded in prolonging the life of any woman or any elderly people of either sex. So if you're old or you're a woman, there is no evidence in the scientific literature that taking a statin medication does anything good for your health. You're just as likely to die as if you didn't take it at all. The new cholesterol-lowering drugs, named PCSK9 inhibitors, are able to lower LDL cholesterol by more than 50%. According to the new guidelines by the European Guidelines for Cardiovascular Prevention, this drug should be added if statin treatment is unable to lower your cholesterol sufficiently. I've talked about this PCSK9 inhibitor before, and it's dangerous. Like, you're talking about really pushing cholesterol levels lower than is normal. And this push to lower cholesterol is just going to end up killing more people. All right, so that's to be used in either healthy people or with people in cardiovascular disease risk. The benefit achieved by using such a treatment is minuscule. In an analysis of 3 PCSK9 inhibitor trials, the authors found that only a total of 37 more people died in the 3 control groups, as the number of participants in the 3 trials was near 75,000 people, half of whom were treated by this PCSK9 inhibitor. It means that if such treatment was that beneficial, it is necessary to treat 1,000 patients for about 2 years in order to save 1 patient from dying. Did you catch that? These PCSK9 inhibitors, which are becoming more popular for lowering cholesterol, it takes 2 years with 1,000 patients taking this for 2 years to save 1 life. That's a number needed to treat that is so minuscule. There's no benefit at all. Why would you do that? Extrapolate that to the general population of millions upon millions of people, and you're talking about hundreds, maybe a couple thousand amongst millions. Is it worth it? That an increased level of LDL cholesterol should be the very cause of cardiovascular disease is also contradicted by the fact that in 6 experiments using non-statin cholesterol-lowering drugs, 132,000 patients who had CVD, none of them were able to lower their mortality with any kind of statistical significance, although LDL cholesterol was lowered upwards of 28 to 64%. In the Illuminate trial, which involved 15,000 people at high cardiovascular risk, half of them were treated with anti-CETP drug torcetrapib, as well as on a statin. Half of them got only the statin. After 18 months, there was a significant increased opportunity of events for cardiovascular disease and total mortality in the drug group, and more died from cancer and infections. These results were achieved although they did see a 28% decrease of their LDL cholesterol. So they lowered LDL, but they died more prevalently. They lowered LDL, but they got cancer, they got infections, they got other things in their health, which again should remind you, the cholesterol is in your body for a reason. Why are we trying to play God, lowering this substance that does nothing but good things in the body? Are you getting the big picture here? And if you've never read my book before and you're interested in cholesterol and you're worried about it, go read Cholesterol Clarity. It's available on Amazon in hardback as well as in Kindle. And I read the audiobook if you want to listen to it. But cholesterol is not the enemy. And this paper is explaining all the reasons why it's not. The increased risk of cancer in the Illuminate trial is in accordance with the fact that in the statin trials CARE, PROSPER, and SEAS, cancer occurred significantly more often in the statin groups. We put a statistic in Cholesterol Clarity that when you take a statin medication, you increase your risk of cancer by about 12%. Did you know that? If you take a cholesterol-lowering medication, did you know that you also raise your risk of diabetes by as much as 14%? You raise your risk of heart disease, which is the very thing it's supposed to be preventing, by about 8%. These things don't get you off scot-free, but people take them as a get out of heart disease free card, and it's anything but that. In the statin trials, non-myeloma skin cancer increased in the treatment groups, and if the figures from both trials are calculated together, the difference between the treatment and the control group was statistically significant. Cancer has not occurred significantly more in any other trial, probably because it takes many years of exposure to carcinogens to cause cancer. In a follow-up study of almost 50,000 patients with hypercholesterolemia treated with a low-dose statin for 6 years, the number of cancer deaths was more than 3 times higher than those whose total cholesterol was low at follow-up compared with those whose cholesterol was normal or high, a finding highly significant. So maybe part of the benefit that cholesterol is doing in your body is working as an anti-cancer agent as well. Yet another argument not to lower your cholesterol. And then the last point, or there's 2 more points, excuse me. Cholesterol lowering does not lower the risk of diabetes. According to the new European guidelines for diabetes, statin treatment is recommended for the prevention of CVD in high-risk diabetics. As support, they refer to 2 experiments, none of which have found the treatment lowers the risk of CVD in diabetics. In a systematic review of high-quality, double-blind control cholesterol-lowering trials, the authors found that lipid-lowering treatment did not reduce mortality and cardiovascular complications. To treat diabetics with statins may actually worsen their health because it's well known people with type 2 diabetes, this is a common side effect of statins. So why, if they know it's a common side effect of statins, why would it be the first protocol to put them on some kind of a statin medication when you know they're going to have an adverse reaction? It's crazy. And now the last point before we get to the conclusion. Cholesterol lowering causes many serious side effects, which I've talked about a few of them here today. According to the authors of these new European guidelines, adverse effects from statin medications are rare, and the incidence can only be obtained from well-controlled trials. It's kind of like what we're having with this V word out there. Oh, it's safe and effective. It's rare anybody would ever have any problem. It's rare. It's so rare. Oh, you've had 5,000 people have effects. Oh, it's rare. It's so rare. Don't get me started. However, the figures from the statin trials are unreliable because many of them start with a run-in period where the participants typically get the drug for a few weeks. After that, those who suffer side effects or who are unwilling to continue are excluded from the trial. Well, isn't that convenient? If they're like having pain in their joints and they're like, I can't stand this, I got to get off of it, they just exclude their data from the trial. So you're not getting the complete picture. In the ideal trial, where a high dose of a statin was compared with a low dose, this method was not used. In that trial, more than 90% of the subjects had side effects. Half of them were unacceptable. Another bias in the statin trials is that muscular problems are only recorded if creatinine kinase, a molecule that indicates muscle damage, is more than 10 times higher than normal. So they have to be really, 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 really bad before they say that there's some kind of a side effect from the statin in the muscles. And we know, if you've ever taken Lipitor, Crestor, Zocor, any of the ors out there, you know they cause massive joint pain in your body. You feel like you're an old person when you're taking these drugs. It's a well-known side effect, but they only measured it if it was extreme. Statins also block the production of both cholesterol and coenzyme Q10. CoQ10, key heart health element, and statins are robbing your body of it. Cholesterol is necessary for a steady renewal of every cell in your body and for the production of so many vital substances. CoQ10 is necessary for all cells to generate energy and normal function. Therefore, it's not surprising that many independent researchers have documented that taking a statin drug may result in unacceptable side effects, which in many cases disappear once the treatment is discontinued. I used to have a lady live right across the street over here, and when I started writing books for a major publisher, and my first book was Cholesterol Clarity with the major publisher, I gave her a copy of it. I had no idea she was on a statin medication at the time, but in her 40s at the time, was not feeling great. She just thought, okay, I'm getting older. This is just what happens. She reads Cholesterol Clarity. She's like, oh my God, I've got all those symptoms in my body. I wonder if it's the medication. So she gets off of her statin. She just stops taking it. And within 3 days, she was completely normal, out of pain. She goes to her doctor and she said, these things are causing me a lot of pain. And I got a book by this friend of mine across the street, Jimmy Moore. You got to go look him up. It was so funny. But like she would have never known had she not known that this could be a side effect. And this is something about the statins I think has never been talked about. They're not making it clear enough that you're going to have some side effects when you take these things. And they ain't going to be pretty. The most frequent side effect is muscle problems, because muscle cells utilize the most energy in the body and are therefore most directly impaired by a deficiency in CoQ10. Considering that today millions upon millions of people are treated with statins, such treatment may be one of the causes of the epidemic of heart failure reported in so many countries. 700,000 people died last year of heart disease. How many of those people died of heart disease because they were CoQ10 deficient, because they were put on some kind of a cholesterol-lowering medication? Something to think about. In accordance, heart failure is now associated with statin use, and treatment with CoQ10 is able to treat it. But how many doctors treat it? How many doctors that put their patients on a statin medication, knowing that it depletes CoQ10, don't give them also a prescription or at least instructions to go buy some CoQ10 to take alongside it? They're not. Side effects of statins have been observed in almost all of your human organs, but in the reports from the statin trials relied on by the guidelines authors for these European guidelines, side effects related to only a few of the organs that are disclosed. However, many independent researchers report statin treatment can cause, listen to this, various eye diseases, hearing loss, kidney failure, bladder inflammation, diabetes, impotence, depression, Parkinson's, Alzheimer's, memory loss, headache, diseases of the peripheral nerves, stroke, heart failure, insomnia, hallucinations, and nightmare. Other than that, you'll be okay. Right. It is therefore not a surprise that several studies have shown that 50 to 75% of those who have been prescribed statin medications as a primary prevention end up stopping the treatment after a short time. People ain't stupid. you go on this drug and you start getting negative effects from it, you ain't going to keep taking it. You'll be like, give me whatever ramifications come with having high cholesterol, because this is for the birds. And I'll say I stayed on it pretty long. I was on Lipitor first for about a year. And then I had an injury with one of my joints. I've talked about this, my thumb. I was playing basketball, went up for a rebound. And those injuries suck with taking the statin. And then I go to see my doctor. Oh, well, we'll put you on a better one. He just put me on another statin. He put me on Crestor. And then after 6 months on Crestor, I had already started a low-carb diet, and then I came off of that. So that's my story. All right, so the conclusion is, in the new guidelines for the prevention of chronic heart disease, blood lipids, and diabetes out of Europe, the authors ignored so many observational and experimental studies that contradict all of their recommendations. So in our expert opinion, medical science is utterly difficult to reject a hypothesis which has been accepted by almost all doctors and scientists for more than half a century. As regards the cholesterol hypothesis, the problem is particularly large because hundreds, if not thousands, of professors around the world within this area of science cooperate regularly with the pharmaceutical companies by producing guidelines for cholesterol-lowering treatment. However, as the number of scientific observations and experiments contradicting the cholesterol hypothesis has increased voluminously over the past few years, we hope that this review that we give today will help our colleagues to stop such treatment. We are optimistic because we have recently presented a paper where we have shown that the cholesterol hypothesis is unable to satisfy any criteria for causality, and hitherto our paper has been downloaded by more than 170,000 readers. The main argument used by the supporters of the cholesterol hypothesis is that the most important cause of cardiovascular disease is dyslipidemia, meaning your cholesterol is high. In particular, it's high LDL-C that they look at. And I'm going to remind you about high LDL-C. LDL-C is an estimated, calculated number. Did you know that? If you follow my work, you know it because I repeat this often, early and often. And here's the funny thing. When you eat a low-carb, high-fat diet, a ketogenic diet, a paleo diet, a real food diet, you typically have lower triglycerides under 100. You typically have higher HDL, the good cholesterol, over 50. When your triglycerides are under 100 and your HDL is over 50, guess what happens to that calculation, that estimation of your LDL-C? It miscalculates it, sometimes by as much as 100 points. And so if you are basing treatment for cardiovascular disease on this LDL-C number, which is highly volatile because it's estimated and based on your other numbers on your lipid panel, can be highly manipulative, that doesn't really tell you a whole lot, it can mislead you. As the commonest cause of death in most countries is now heart disease, it is a strong contradiction to the idea that no follow-up study of elderly people has ever shown that those people with the highest LDL-C have lived a shorter life than those with a lower value. In most of the 24 follow-up studies that we previously mentioned, it was exactly the opposite. And after the publication of the guidelines, at least 8 follow-up studies with similar results have been published. The fact that some people with familial hypercholesterolemia die prematurely because of coronary heart disease has been considered strong proof of this cholesterol hypothesis. What is little known, though, is that only a subset of these suffer from premature CHD. Supporters of the general view often refer to Nobel Prize winners Goldstein and Brown, but what these researchers found was the reason why cholesterol was higher than normal in those who have familial hypercholesterolemia, not that it was the cause of their cardiovascular disease. It is, of course, difficult for a professor to admit that what they've been taught and what they have taught to students in the general population for years is wrong. This realization is even more difficult to accept if the hypothesis has resulted in prescribing drugs which have questionable benefits to millions of patients and healthy people around the world. However, we do have great respect for anyone who dares to stand up to the system. So, a relevant question, and we're finishing up, is why the guideline authors continue to recommend that people with high cholesterol should lower it as much as possible. According to the authors and the reviewers' conflicts of interest, which included 150 pages of information, almost all of them, listen to this, in this European guidelines for the prevention of cardiovascular disease, almost all of them have relationships with pharmaceutical companies. Dun, dun, dun. I just did a post today on social media that talks about that very thing, that when I first came on the scene in 2005 blogging, I noticed we had two big enemies. It was Big Food and Big Pharma. And Big Pharma is very powerful, and they persuasively, I posted the link to a review article from 2013 that showed they basically dominate healthcare. And the way they do that is they pour money into buying doctors, buying every entity within the healthcare medical system, buying the medical schools, buying the boards that look over, buying these journals that we read these studies from. So when you own everything, you can say whatever you want and you think you get off scot-free. And so all of them have a relationship with the pharmaceutical industry. Some of them, more than 12 different drug companies. I guess it pays to be a bought and paid shill for the pharmaceutical industry. It is possible that this may have influenced them. Oh, you think, Uffe? We therefore suggest that future guidelines for optimizing prevention and treatment of people at risk for cardiovascular disease should be created by independent researchers based on a systematic review of the literature. Well, the problem is, are there any? Are there any truly independent? I suppose this group of researchers on this paper would be considered independent, but man, what do you think about this? This again, by the way, if you came in late, expert review of clinical pharmacology. It's a brand new review paper that just came out last week, and it's by Uffe Ravnskov and others. The new European guidelines for prevention of cardiovascular disease are misleading. Really fascinating information in there, and I love it that we have such truism about this cholesterol story because, yes, I wrote a whole book about it 8 years ago. And here we are in 2021 still having the same arguments, the same concerns about cholesterol and it trying to mean something in your health. It really doesn't. All right, let's see what you guys have to say. We're going to come here first to Instagram, then over to Facebook, finally over to Twitch. Thank you all for being here today on Jimmy Rants. JimmyRants.com is the website. And who has the first comment? Britt does. I had a doctor once want to put me on a statin medication. Her words were, quote, "I will find you one that won't give you too many muscle aches." Like this is normal. No, see, the problem is all the statins deplete your body of CoQ10. And so it's the depletion of CoQ10 that causes those effects. I wonder if in the manufacturing of this drug, once they discovered that it depletes the body of CoQ10, they come out with Lipitor Plus, and they add CoQ10 to the Lipitor so that maybe it ameliorates some of that effect. But they didn't ask Jimmy Moore's opinion. But yeah, there's not many cholesterol lowering, but you don't need to lower your cholesterol, as you well know. Stacy says, do you link the article and studies you mentioned somewhere? Thank you for this. So that's why I read very clearly what the title is and what the journal is. So you can go look it up. Sometimes in the notes, when I put it on IGTV, I put it down in the notes, or I guess it's up there. Click on that little arrow and it drops down, and then there should be a clickable link. I try to put that in there when applicable. I don't always do that, but the title of it, The New European Guidelines for Prevention of Cardiovascular Disease, are misleading, and it was published in the journal Expert Review of Clinical Pharmacology. And like I said, it came out last week in that journal, so you can go look that up and get a copy of the paper. Can low CoQ10 cause problems with fat loss, says Joshua. I don't know directly, Joshua. The only mechanism I can think of is because it depletes normal processes in the body. I would assume some of the processes involved in fat loss would have to go compensate for that depletion of CoQ10. So indirectly, maybe. I don't see why it would directly impact fat loss. All right, thank you, Instagram. Let's pop over here now to Facebook, and then we'll come over to Twitch. Facebook, you're completely silent on me today, but thank you for being here. Appreciate you guys always watching. All right, now let's come over to Twitch. What's up, Twitch? I saw the post about animals getting the V word. You got to be kidding me. Yeah, exactly. Oh, yeah. That's another topic for another day, Saya. Cariana says, every time we hear these, I get so frustrated. The evidence is right in front of these people's faces, and yet they choose to ignore it to the detriment of everyone. Arg, how do they sleep at night? Well, Cariana, that's the thing. When the kicker at the very end, when he made the point that almost all of them have a relationship with the pharmaceutical industry, and some of them over 12 different drug companies. I don't think we give enough credence to how much information, research about our health is bought and paid for by pharmaceutical. It is. And the sooner you realize that is the sooner you stop believing them. And in that post I wrote today, by the way, I said, well, in light of this, why are people so trusting of what they're hearing about the 9,1-divox V word? These are the same people that have lied to us about cholesterol being the enemy in your health. These are the same people that have not had our best health interest in mind. So why all of a sudden do we have an epiphany that makes us think that they're on our side now with this new drug? Makes no sense to me, but you're right. I guess they enjoy their fancy yachts and their nice vacations that they get to go on for being a shill for statin medications. It's unfortunate, but it is the world we live in. So there you go, guys. The European Cardiovascular Disease Guidelines, they're very much similar to what we have here in America, and highly, highly, highly misleading. Hopefully this armed you with a lot of really great information. I will try to link this paper into the notes so that you can click on that and take a look at it. But thank you guys so much for being here today. And that's it for this episode of Jimmy Rants. JimmyRants.com is the website. And as always, you can engage live in the content. Come follow me right here over on Instagram at Jimmy Rants is where I'm at over there. Monday through Friday, 11 a.m. Eastern Times when we go live. Appreciate you guys being here today. We also simulcast over on Facebook. My total cholesterol, LDL cholesterol is 275. Yeah, that doesn't mean anything, Sharon. A 275, yes, I suppose you could say that's a high LDL cholesterol, but without context. What's the particle size breakdown? Is it mostly large, fluffy, or small, dense? Is it atherosclerotic? Do you have high inflammation levels? Like, there's so many questions that one marker like that doesn't really tell you anything about your health. We also simulcast over here on my Twitch page. Thank you guys for being here today. And just a reminder to everyone, go download the Twitch app. Put it on your phone. It should be available in whatever store you get apps from. Put it on your device. And then you can download the Twitch app and start following Jimmy Moore Rants. And you'll be able to get the show. My C-reactive protein is high. What does high mean, Sharon? If you missed the live, you can watch it on the replay right here on the Jimmy Rants Instagram page. It goes right up onto IGTV, so thank you so much for watching if you're watching the replay. It's also available for replay over on Twitch, also on YouTube. It goes up there just as soon as the show is over as well. And then, of course, over at jimmyrants.com, HbA1c 95. So, yeah, you have high inflammation with that high LDL. So you would be somebody that needs to try to figure out ways to lower your inflammation. See what's causing the inflammation in your body and getting that down. Not worrying about your cholesterol. Your cholesterol is high because your C-reactive protein is high. You get the C-reactive protein down, and that cholesterol will go down naturally. You see why you have that high LDL now? That doesn't surprise me that you have a higher level of inflammation. All right, guys, tomorrow I've got another study I'm going to read to you from Dr. David Ludwig et al. Again, that came out just last week, hot off the presses from the Journal of Clinical Investigation. And it's all about carbohydrate restriction for people with diabetes, rediscovering centuries-old wisdom. They were using carb restriction to control type 2 diabetes way back in the 1700s. And you're going to learn all of that history tomorrow here on Jimmy Rants. So we'll see you at 11 a.m. on Wednesday. Bye.